Hi everyone. Thank you so much for attending tonight. We're really happy that you've joined us tonight, and we're really excited to have Maura Harris with us today to give a presentation and then answer some questions on her work and experience in the program through the School of Global Public Health. But before we begin that, we wanted to give you all a brief introduction to the 2020 Public Policy Symposium. So the symposium is an annual event sponsored every single year by the Politics Society, and that's the school's largest nonpartisan political group on campus. And this year, co-hosted along the NYU School of Global Public Health. Each year, students from across the country and from a diverse range of ideological, geographic, experiential, and otherwise backgrounds descend upon New York University's main campus in Lower Manhattan this year, virtually, of course, for a formal weekend-long debate on some of the most salient issues of our time. And the aim of the symposium is quite simple. We want to end the weekend, this weekend it's from November 14th through the 15th this year. We want to end that weekend with a powerful slate of consensus-based proposals to demonstrate that such policies that come from rigorous and open exchange are still attainable and effective. And so participating in the symposium allows students to gain a better understanding, not only of the topic at hand, but also of really valuable skills like public speaking and leadership, debating and policymaking, among others, and network with people and organizations from a wide variety of fields and professions. This year's symposium, as I'm sure you all have come to know by this point, is centered around public health. With subtopics including, though not limited to, pandemic preparedness and response, of course, but also environmental impacts on community health, gun violence, and housing. And in addition, we're paying particular attention to encouraging participants to pay close attention to the way that all of these issues are impacted by social determinants like race, socioeconomic status, and geographic location. So that was a lot. So if you have any questions at all, please feel free to reach out to us at publicpolicysymposiumnyu@gmail.com. We'll be glad to answer any questions there that you may have. So now I'll hand it over to Taylor to introduce Ms. Harris.
Hi, everyone. I have the pleasure to introduce our guest speaker today, Maura Harris. Maura currently serves as a policy and advocacy manager at the Primary Care Development Corporation, where she works to expand PCDC's local, state, and federal policy efforts. She has worked previously as health advocacy lead at Galileo, a primary care provider group, and in administrative roles at One Medical. Before completing her MPH in health policy at the NYU School of Global Public Health, Maura graduated from the University of California, Santa Barbara, with a BA in sociology and a BFA in dance. Today, she is going to be speaking about her work with PCDC and primary care advocacy and answering any questions about her presentation and kind of career path related questions as well. So if you do have a question, please feel free to shoot it in the chat. And then also when she finishes her presentation, Maura is happy to do a question and answer if you would also like to ask your question verbally. So that is okay too. So with that, I'll turn it over to you, Maura.
Thank you. Thank you both so much. And thanks to everyone who joined. I'm really excited to be here, and I'm excited to hopefully get to know all of you a little bit later after I give just a brief presentation. I know that we already have a couple of questions that came in, so I'm excited to chat. As was mentioned, I'm policy and advocacy manager at the Primary Care Development Corporation, PCDC for short. And just before I get into my presentation, just a brief background on PCDC. We're a national nonprofit, and we're also a US Treasury certified community development financial institution. So we sort of have three legs of business, and so just very briefly, the first is our capital investment team, where we provide capital financing to primary care practices across the country that are looking to either build, expand, or enhance their facilities. The second is our technical assistance legs, where we have a team of content experts that go again across the country to provide trainings and technical assistance on a variety of topics, care management, coding, things of that nature. And then, of course, we have our policy, advocacy, and communications team where I sit. We work really closely and in tandem with our evaluation and analytics team to sort of research and analyze policies at every level of government, local, state, and federal, that pertain to primary care. So we're disseminating our own research findings, but also tracking and responding to proposals or initiatives that come out at each level of government that impact primary care, often in the form of public comments, recommendations, or conversations with government officials and healthcare leaders. And let me just share my screen and get into this presentation here. One of the things that we as an organization are really excited about right now is the launch of a campaign that PCDC is going to be leading on the issue of primary care investment here in New York State. I don't want to spend too much time because I do want to save time for questions, but just the way we're going to do this is I'm going to talk a little bit about the background of the issue of primary care investment, give you some examples of how other states have tackled the issue, and then go over the sort of characteristics and key aspects of a campaign like this, the evidence that we have about the impactfulness of primary care investment, and how PCDC is going to be facilitating the campaign. And so I think it's really helpful to sort of do a level setting first. One of the things we find actually is that lots of people actually don't have a super strong idea of what primary care is. I'll just say that there's actually no national sort of consensus or standardized definition of primary care. So there's been a few groups, that have put out their own definitions and so forth, but really the sort of guiding light that we have is Barbara Starfield, who was a pioneer in the field back in her day, several years back. And to put it in a way that's sort of like relatable, I guess, to most people, primary care is your general practitioner, right? It's who you go to see for a cold, for a sore throat, for your annual checkup. And Barbara Starfield sort of laid out the 4 pillars of primary care. She referred to them as the 4 C's. So primary care is often the first and sometimes the only contact with the healthcare system for many patients. It's comprehensive in that it takes into account all aspects of a person's health and well-being and the factors that contribute to it. It's coordinated with the other parts of the healthcare system that a patient might interact with, and it's continuous. So the relationship between provider and patient happens over a long period of time, can be from early childhood to end of life. So I think that's just a good place to start so that we're all sort of on the same page when we're talking about primary care. And then on the issue of investment in primary care, I think we're all very well aware that healthcare spending in the US is extremely high. I think what's less known is that it's very imbalanced. Because like I said before, there's no real national definition of primary care. It's sort of difficult to compare primary care outcomes and investment across states or at the national level. But it is estimated that about 5 to 7% of the healthcare dollar goes to primary care. And that's abysmally small, right? That's teeny tiny, especially, when we think about, there was a 22 OECD country analysis that showed that about 14% of spending there was going to primary care, which is, double, almost triple what we're spending here in the US. And so what's happened because of this lack of investment is that very few of us, or not enough of us, have a regular primary care provider. Only about a quarter of us do. And that's a big problem. I view it as a problem. PCDC certainly views it as a problem because we have this plethora, this library of research at this point that shows how impactful primary care can be, both for health outcomes and health status and for costs. I really love this statistic that, the increase of just one PCP, primary care provider, per 10,000 people can reduce the need for hospital and emergency room visits and surgeries pretty drastically. And so it's sort of with this conundrum as a backdrop that there's been sort of a movement over the last several years to, at the state level, to rebalance healthcare spending. And so we're going to take a look at what that has looked like. So the first state and really the pioneer in this movement was Rhode Island. In 2009, the health insurance commissioner required the plans that he oversaw, his office oversaw the commercial plans to increase spending on primary care by 1% per year over a period of 5 years. And they were successful, right? Spending on primary care increased by 5% over that time period. And importantly, over that same period of time, total health expenditures decreased by 14%. And so this success in Rhode Island sort of set off a domino effect. So as you can see, several other states have acted in the years that have passed since in various using various approaches. So of course, Rhode Island used with the regulatory route. Washington decided to use a budget appropriation before taking it a step further to introduce some legislation. Connecticut used the governor putting out an executive order, and the rest of the states have chosen a legislative route. And so since the majority of states have chosen the legislative route, and that's also the route that PCDC is taking New York, that's what we're going to sort of focus on when we dive deeper into what this campaign is going to look like. And so in most states, in essentially all of the states that have gone the legislative route on this effort, the primary goals of the efforts have been to define, measure, report, and then ultimately increase the investment going to primary care. And so while this specific phrase isn't necessarily in any of the legislation to date, it generally captures the steps required to get to an actual increase in funding for primary care. And so we'll talk about why each aspect of this goal is important. Some of the key sort of pieces of the legislation in most of the states thus far have included the development of a technical definition of primary care. And so we'll talk about why that's probably different than the idea of a definition of primary care that you and I probably have in our heads. And then the development of a sort of process to measure the actual expenditures. And finally, a governing body, so a group of people to sort of oversee the measurement and reporting activities. So we'll look at each one of these a little deeper now. Firstly, I think, and probably most importantly, why do we even need to define primary care in the first place? Why can't we just take, whatever definition we like the best? It's really because, when you and I talk about primary care, we sort of talk about it the way that Dr. Starfield does. It's the first contact, it's preventative, it's coordinated, et cetera, et cetera. But when we're thinking about actually measuring the services that are provided in primary care and how much money is going to them, you sort of need a way to actually count and add things up, right? And so that warrants a different type of definition, a more technical definition. So we're going to use Oregon as a sort of case study from here on out. The definition in Oregon is sort of based on the healthcare provider that is providing the service and then what that service actually is. So taking a little bit of a closer look here in Oregon, for example, in Oregon, the claims paid for a patient wellness exam by a family physician in a clinic are considered primary care spending. So primary care is defined as a set of procedures and activities performed by certain types of providers. So this way, insurers can add up all of the money that went to only those services provided by only those types of providers, and then report the total amount of dollars going to primary care. Now, in most states, the development of this technical definition has been left up to the commission or collaborative that's convened in the legislation, that governing body. And as you can imagine, it sort of gets to be a hotly debated topic across all of the various stakeholders sitting at the table. Typically, the discussion focuses around whether to include behavioral health providers, whether to include women's health providers. And, you know, especially because the more provider types and provider or service types that you include in your definition, the higher the spending measurement is going to be, right? And so states have taken various approaches to this. As you can see, Oregon chose a fairly expansive approach, including naturopaths and psychiatry. Others are a bit more restrictive. But it's, you know, a really interesting thought, I think. I mean, in your minds, when you think to yourself, what is primary care? What would you include in a definition, right? And that brings me to another really important piece of this legislation, which is how you're actually measuring the spending. And this can get super, super data-y and complex, so I don't want to get too deep in here, but one of the challenges that has arisen in measuring primary care expenditures has been sort of the growing proportion of that spending that's been under value-based arrangements. And I'm sure that some of you have actually probably even taken the whole class on value-based payment, or you can, I'm sure. I did. So I won't get too deep into what that is, but just in a nutshell, you know, we talked about how one way to measure spending on primary care would be to say when a family physician, for example, bills an insurance plan for a qualifying service, say a routine office visit, and that's what we call a fee-for-service visit. So relatively simple to measure, right? It's every time a service is delivered, a claim is submitted, and the insurance plan pays for it. But now imagine if an insurance plan gave a provider one really big chunk of money to care for their entire patient population each month. So under these types of value-based arrangements, it's more difficult to determine the proportion of dollars going to qualifying primary care services because there aren't specific individual claims being submitted. I had a conversation with a woman in Vermont, which is one of the states that has done this, who said that they actually deliberately left out about $200 million flowing through their healthcare system because they just hadn't really nailed down an accurate way of depicting how much of that went to primary care. So, you know, fee-for-service payments are familiar to insurers. It's what they know. It's easy to measure. Value-based payments are newer. They're more complex. It's harder to measure. So there's been some challenges that many states have faced. That being said, most states have recognized that it's actually pretty important to attempt to measure the non-claims-based payments, given that that's really like sort of where the healthcare system, the delivery system and payment system is moving towards the future. There's going to be a growing amount of dollars flowing under value-based arrangements. And finally, just very quickly, this governing body. So in almost all, I think all of the states that have passed or introduced legislation so far, it's included a commission or a collaborative convened for the purpose of overseeing the duties outlined in the legislation, which include the development of a technical definition, the development of a measurement process for the insurers that are required to participate, and then analyzing the findings on the measurement, on the spending, so that they can then provide recommendations for how to increase that spending. And so, you know, for me, I think, you know, I can explain all of that and it sounds all well and good and sounds great. I mean, it probably sounds really boring actually to most of you, but it's, you know, whatever. It sounds, you know, great. So whatever, who cares? What matters is whether or not it's actually benefiting the people on the ground. Is it actually having an impact on the providers and the patients? And the evidence that we have so far is really pointing to a resounding yes. Oregon has been doing this the longest, so they have the most data. And really it's showing that primary care spending as a proportion of total state healthcare spending has increased pretty drastically. I will just, as a little caveat here, say that Oregon is the only state so far to actually mandate an increase in spending. You know, after they introduced their 2015 legislation, in 2017, they actually amended it to require, to mandate that payers increase their primary care spending. So no doubt that has something to do with their success. thus far, the other states are too early in their processes. So what's sort of yet to be seen whether an increase will happen just from the measurement and reporting, or if, a couple years down the line, maybe they'll find it necessary to amend and require that increase as well. But the bottom line is that, it's working. 400 million extra dollars were flowing to primary care in this 3-year period in Oregon. And what does that mean, right? It means that primary care providers had more sufficient funds to expand services, to hire more staff, to increase pay for their staff, whatever it is, to increase, essentially they're increasing the access and the quality of their care. And that means that the patients are getting better and more primary care, and that's really important. And so that's, I think, why we're really excited at PCDC to be launching this campaign here in New York. I think, if New York is to remain a leader in progressive health policy, I think this is really sort of the correct next step. And I will say that I think this moment of pandemic and all the many other things that are happening is actually placing a sense of urgency on the issue. So I think, we've seen that COVID-19 has shed light on the importance of investing in primary care. I think the direct effects of ignoring primary care has left New Yorkers, particularly Black and Brown New Yorkers, vulnerable to COVID-19 through excess chronic disease and unmanaged care. Our own research, PCDC research, has shown that many New York City areas that were most affected by COVID-19 have the least primary care access. And so the pandemic has also reduced health sector jobs by a significant portion. And at one point, primary care visit rates were down by 60%. And so those PCPs that were still being paid on a fee-for-service basis had to scale back their hours, close their doors, and that's devastating to areas that are already affected by low primary care access. And I think as we continue to fight the COVID-19 pandemic, it's just going to exacerbate disparities, particularly as we move towards an increasingly virtual healthcare environment. Primary care providers need adequate resources to implement those services and to implement that type of care effectively. And I actually think that what we're seeing is a bit more of a political appetite at the state level, given the sort of temporary changes that have been implemented surrounding telehealth and the other sort of reimbursement discussions that are being had. There's a bit more of an appetite to pass a policy like this that would sustain primary care providers in the long term. And I think, tied into this issue of the pandemic inherently is, in the wake of the movement over the last several months fighting for racial justice, I think we're hopeful that lawmakers will look at the evidence and reckon with the fact that the lack of investment in primary care has in part resulted in disparities that we're seeing in the pandemic, not only in the pandemic, but in chronic disease management. Many of the neighborhoods with the high rates of COVID-19 infections and poor primary care access are the low-income neighborhoods of color. And those neighborhoods also have the least primary care access. Deferred primary care, which has been a phenomenon over the last several months due to social distancing requirements and a fear of, contracting the virus, has actually led many experts to predict a second pandemic, what they're referring to it as, where the lack of the sort of delayed and foregone care will actually exacerbate the chronic diseases that are disproportionately high in low-income neighborhoods of color, and it will create sort of a twindemic. So without, sort of targeted relief for these neighborhoods, I think that we're looking at sort of a reckoning of, I can't really think of a better word for it. We know that these Black and Brown communities suffer the most from these chronic diseases, and have the least access to the resources to mitigate harm. And so while investment in primary care is only one tiny slice of the health equity pie, this is an area that we feel we can contribute to that might move the needle. And so what is PCDC going to be doing? We are, over the next months to years, it's hard to predict how long these things will take. PCDC will be launching a statewide campaign to identify barriers and opportunities to rebalance New York State's health system. We'll be leading the charge to convene a statewide coalition of primary care champions to secure stakeholder commitment and to support increased investment in primary care. We're hopeful actually that this sort of coalition will be sort of a constituency of a wide variety of stakeholders that will help to ensure a primary care focused health system in the long term, even beyond the legislation. And so we're going to host events to increase awareness and raise support for the issue and work with our partners at the state level and the leaders in New York State healthcare to hopefully pass this bill as quickly as possible and move on to the next issue. So that's it. That was a lot, and I apologize if I was speeding over some things that were maybe confusing or using language and acronyms that, alphabet soup that were not that were not understandable. So I'm happy to answer questions.
Perfect. Thank you so much. I think we can start with this questions that were submitted before while everyone else has questions kind of stewing. But again, feel free to submit any questions in the chat, or you can use the raise hand function and we can do it that way as well. So let's start with a question submitted by Joyce. As an advocate for primary health care, how do you address the impact of adverse childhood experiences on adult health in the underserved community?
That is a great question. Well, first, let me do a little plug for PCDC. It's funny you asked that because we just today launched a 6-part free webinar series on ACEs. That's what our technical assistance leg is sort of, that's in their wheelhouse. So it's a monthly webinar that will be held. I can send the link that gives sort of introduction to trauma-informed care and what ACEs are, and then as the series progresses, it assists providers, mostly targeted towards small and medium-sized practices, but anyone is welcome, of course, that will assist them in screening for and treating symptoms of ACEs. And so I think from a policy perspective, in terms of primary care, I think one of the best ways that we can advocate for improved care for populations that suffer from the effects of ACEs. One is advocating for really, I would call it whole person care and comprehensive primary care, because in my mind, true comprehensive primary care is trauma-informed care. So that is sort of one of the services actually that PCDC really focuses on in terms of our technical assistance is training providers on how to provide trauma-informed care. Programs like the patient-centered medical home or health homes are really good at this. So we are big proponents of those types of programs. The other thing that I would just say is that I'm a big proponent of a health in all policies approach. And so I really truly think that if, the folks working on education and housing and food and all of this, we're working together and we're well informed on an issue like ACEs, there are ways to mitigate the circumstances that lead to a child suffering from an adverse event. So that's my answer to that. I hope that was helpful.
I'm on mute. Sorry about that. Happens every time. Another submitted question by Cara was, at what point in your undergraduate career did you decide you wanted to get your MPH?
it didn't happen in undergrad for me, actually. I mean, this could be a very long story, but you probably heard that I grew up as I got a BFA in dance. So I grew up as a dancer, and I got a second BA. I got it with double majoring. So I did sociology as well, but I was really focused on dance throughout undergrad. And that's actually where it brought me to New York. And while I was dancing, I actually got a job at a doctor's office, and that was sort of the spark. I started at a doctor's office, sort of working at the front desk, and moved into a lot of different roles. I was a phlebotomist, tried my hand at the clinical side of things for a while. And sort of after trying out a few different things, I realized I was really interested in the sort of behind the scenes, big picture policy stuff. And so I decided to apply for my MPH, and here we are.
Awesome. We have a question from the chat that just came in. Let me see if I can pull it up here. Okay, so this is from Rahul. He asks, could you speak a little bit more about the capital investment team, how they evaluate, and what kind of people do they hire?
Sure. So our capital investment team, so let me just say that coming into PCDC, I've been with PCDC now for almost a year. And of course, my background is purely healthcare related, public health. And so that side of the PCDC business was totally new to me. Like the community development and investment was a big learning curve for sure. And I am by no means an expert still, but it's really been such a privilege to be able to learn about it, and particularly through a health lens. Community development, I think, is something particularly within the CDFI space, is not sort of given enough attention, I would say, in terms of, again, like this is sort of, for me, a health and all policies approach, like lending and investing in communities that have historically been disinvested from or sort of left behind is key to sort of revitalizing those communities and ensuring that well-being is kept. So the capital investment team, it's a team of like very distinguished experts, and sort of with a history that mostly their background is in, they've worked at banks before or in other CDFI, so they really have a investment or lending background. And what I think what makes PCDC stand out within the CDFI space is that most CDFIs or lending institutions aren't necessarily specified or specialized, I should say, in a particular field. The lending essentially, they lend to small businesses or just sort of whatever project comes up. PCDC really were experts in healthcare. And so we know how to leverage funds in a way that is really effective for healthcare, particularly primary care facilities. And since we we're a mid-sized CDFI, I think we have a sort of a leg up in being able to connect with the communities and hear from them about how they want to use the money, what's going to be the most helpful to them, so that we can give them a facility or an expanded facility or an enhanced facility that is tailored to what's going to be most beneficial for the providers and for the patients. In terms of hiring, I don't know that I can speak to that. Currently, I don't think we're hiring on that team. But if you're interested in it, I can definitely send you more information on just community development in general, or the CDFI space in general, because it really is really interesting.
Perfect. It looks like we have a hand raised. So Matthew, whenever you are ready.
Hi. So you touched on it a little earlier about like telehealth stuff. So I was wondering if you kind of talk about what what you maybe specifically are doing, or the company as a whole is doing to try to expand telehealth, especially within, I don't know, maybe like lower income communities and stuff like that?
Yeah, so it's a great question. PCDC has actually been doing a whole lot on telehealth. We really ramped up that. That again is sort of in the wheelhouse of our technical assistance leg. That team, it's called the Clinical and Quality Partners. But really, we've like developed an entire sort of program full of webinars and trainings and resources for providers that help them to implement or enhance their telehealth capabilities. In terms of policy, I think what we're working on is, you know, advocating for, in New York has great telehealth policy. I think, you know, advocating for the extension or permanence of a lot of those policies that have been implemented as sort of a stopgap for the duration of the public health emergency, and working with our partners that have a really big voice at the federal level to do that as well, because of course CMS has been actually doing really good things for telehealth. We just really want those to stick. One thing that's interesting about telehealth, I think, for us is that like government and like the regulations around you know, the requirements or the restrictions around some of these things like telehealth, typically we're told, you know, these are set in stone. It will take an army to, you know, erase them or repeal them or change them, and it'll take so long and there's no point in even trying. Clearly, over the last several months, it's happened very quickly. So I think that the things that have been happening with telehealth and payment policy, to frankly, have really been a sort of example of how quickly government can move in terms of regulation. So I think that that's both heartening and disheartening, right? Because it's good to see because it's possible, but it's also it's sort of upsetting because, you know, you look back at all the times that you tried to do this before and it didn't happen. But I think that it is like sort of setting a precedent. So hopefully good things will come out of it in the future.
Terrific. We have a question that was submitted prior from Neoma. I hope I'm pronouncing that correctly. And it says, what are the careers that you can go into in global public health? And a second part of that, what are some suggestions you have for someone studying global public health right now when it comes to school?
Whew, I mean, the possibilities are endless. Like if I'm talking specifically global public health, like the track on the global track, I have a couple of friends that were in that track and are now working on you know, program evaluation in a foreign country. And those are like really impactful ways to engage in the international public health sphere. In terms of, I'm not sure if you're just speaking about, you know, the global public health school in general, because there are of course many other tracks, and if we're looking at sort of just public health as a whole, I mean the possibilities are endless. You know, I have this is my first time working in like the nonprofit government space, so that is certainly one track, and even within that there's a million options, but that's not the only place to go, right? You can 100% work in you know, you could go work for a pharma company, you could work for a doctor's office, you could manage or do administration at a hospital. I think working at community-based organizations as well, like being sort of the health lead for a community organization is also something that's really impactful. So maybe somebody who has the expertise on health, that is maybe works at an organization that is not specifically focused on health. I think one of the things I'll say is that, you know, the 5 years before I came to PCDC, I worked in mostly patient-facing roles. So I was working directly with patients and with providers. And that was, I think, actually really helpful for me going into a policy role. So, you know, using the experience that I had on the ground with the patients and with the providers has really informed the way that I think about policy. I think that's really important, actually. I think that, you know, policy can get very ivory towery. It's easy to get separated from the people on the ground and the patients that you're making policies about or for. And that makes for bad policy, right? So I think all of this to say that you don't have to limit yourself to one particular area, right? Like definitely explore, make yourself a well-rounded public health professional. That's the most effective professional. In terms of advice for while I was at school, utilize your professors. I was just talking before this started that let me just call her out, Dr. Diana Silver. she was like a huge part of what got me really excited about public health policy. I think she made me a really good policy analytic person. She just like really influenced me in the way that she thought about policy, in the way that she taught policy and how she talked about it. I think that using those connections are actually really important. It sounds like a cliche, but like that's what they're there for. She, you know, has written me letters of recommendation. You know, the other professors can you know, use your the research that you did for them to like talk you up. I would say that's like a really great resource that you shouldn't take for granted.
All right, next, I'll turn it over to Michelle, who has a question for you.
Hi, Mara. Well, my question is, earlier in the presentation, you mentioned about PCDC's policy advocacy. So I always, because I'm always thinking about this population, so my question is if PCDC has allocated any efforts to ensure that primary care is provided to individuals who don't have insurance or aren't eligible for insurance, such as the undocumented community.
Absolutely. So we, you know, PCDC is actually very focused on the underserved populations. So that's really our target population, and that to us includes, you know, a sort of variety of subpopulations, including the uninsured and the underinsured. So we're really huge advocates for the safety net hospitals and clinics that provide, you know, affordable care to those who can't pay or have Medicaid insurance. That's like a really big, that's who we are. That's who we advocate for. And that 100% includes undocumented immigrants. Actually, you can take a look on our website. We actually submitted some testimony on a couple of months back. The state legislature was holding a hearing on the disparities that were appearing in during COVID, racial disparities. And one of our recommendations to the state was to extend insurance coverage to all New Yorkers, so that you know, eligibility was not going to be a barrier to care, particularly during a global pandemic. So hopefully that answers.
Awesome. It looks like we had another question submitted through the chat. So Narisa asks, what are your thoughts on the dual degree MPA/MPH program?
I haven't really given that one too much thought. I certainly, you know, knew people who were doing the MPA because our classes overlapped. I think it depends on what you want to do, honestly. I think it depends on what you want to do with it later. I would maybe argue that if you're really interested in the sort of like administrative aspect of healthcare, the MPA is maybe a good way to go. I don't know that it's necessary. I will just say that.
All right, and then we have another pre-submitted question. Indu asks, what kind of experience is required to get into policy and advocacy organizations? And is it different between like an MPH or an MD degree?
Well, so let me just, the requirements, there aren't really, I will just say that it depends on the job, but for most policy jobs, the requirements vary. There isn't like a standard, this is what you need to have to do this work. So obviously higher education, MPH, MD, all of that's going to be helpful to you on a resume. But don't let that discourage you. Like, not having those degrees is not going to be necessarily a barrier for every job that you apply to. So I think like I said, having that sort of patient-facing experience for me was actually a benefit to me in the interview process for PCDC. That was like a good thing to have on a resume for going into the policy field. And so I think just, tailoring your work experience to where you want your career to go. I don't think that you should necessarily think that you have to go on a certain track to achieve what you want to do.
Awesome. We have a raised hand from Joyce.
Now, I'm a nurse practitioner. I did my MPH at NYU some time ago. But one of the things that I find with the people in underserved communities, they're not quite sure about where to go to get their needs met in terms of primary care. How do you guys go about informing those patients? And do you involve the community at large? Bring the community in to at least, to inform because a lot of patients come in, they have no clue which end is up. They do not know where to go. So one of the things we try to do is, have you spoken with your community leaders? But they don't seem to know where to go to access services, to get help. And forget primary care, the ER is their primary care provider.
Absolutely.
And that is really sad.
I completely agree. And actually at my previous position before PCDC, I actually worked as I had a lot of hats, but I worked as a case manager for we were mostly contracted with medically complex patients for Medicare here in New York. That was exactly my experience, was that mostly those patients were going to the ER for all of their care. That was, where they were going to see any type of doctor whenever they had any type of issue. For us at PCDC, I think what we do, and this is again sort of in our technical assistance leg, this is their wheelhouse. We have really strong partnerships with other healthcare organizations in the community that we use to essentially amplify the importance of what we do and the importance of our primary care clients. So because we have these really strong relationships with these sort of community, these organizations that are really immersed in the community, we are able to sort of translate the message that we want to get out about the importance of primary care and where this is happening in their community in a way that is accessible to them. Because a lot of course, if we try to do it, oftentimes the we don't have to have the direct contact with the patients that we would like to. And so
Mhm.
that's where we use the sort of community-based organizations to translate that, get the message out and especially translate the message in a way that is culturally competent and health literate and all of the things that are important in order to actually communicate a message. So that's really, I think, that's a really big strength of PCDC, is that we do have a lot of really deep connections with a lot of well-known organizations across the state and across the country.
Mhm. Thank you.
Awesome. We're going to take the 2 final questions in the chat, but before we do that, I don't know if you saw the wonderful affirmation from Dr. Silverman. You should check that out.
Oh. Oh. Oh, Dr. Silver. Thank you. Miss you.
So first question we'll take here from, let's see, from Miles. So Miles asked, when you were in your master's program, what did you look for in an internship and how did you go about securing that position?
Great question. I actually went maybe a route that most people don't take for my internship. I was already working at my previous position, and because I was working in a organization that was very primary care focused, healthcare focused, I was able to find a way to work with people that were, not in my direct unit, to sort of create new projects that became like an in-house internship, essentially. So I got very lucky in that sense, because I was able to just sort of stay at my place of work. But that's an option if that's something that, if you really like your job, that's definitely something that you can work out. I know plenty of other people who had great experiences going into a new place though. So either way works.
All right, perfect. We'll finish it up with our last question from the chat. So this is from Charmaine. They ask, I know that your work focuses on, your work focus in PCDC is on policy, but what other skills do you think are essential for you to be effective in your job? For example, like certificates or social media skills or anything along those lines.
Oh, that's really interesting. Well, I'll say that actually, I've been exposed and have developed some skills in communications. Just the nature of advocacy involves comms. And especially because, at PCDC, policy, advocacy, and comms are all housed in one unit. And so I've learned a lot about those sort of social media platforms, messaging platforms, and things like that. But in terms of soft skills that I would just plug, I think learning how to run a meeting is really important. Collaboration is really important. And I think those are actually really good things that actually, NYU the MPH program talks about this a lot. And I remember hearing it over and over and over again when I was in school, but it's really important. Those are I think that actually the MPH program does a good job of us trying to prepare you for, with the group projects, as nightmarish as they can be, they really are helpful. So that's what I'll say about that.
All right, perfect. Thank you so very much for giving this wonderful presentation and taking time out of your day to answer questions from students and alumni of NYU. We really appreciate it, and I definitely think that it was informative and enlightening, and will really be useful for students who choose to participate in the Public Policy Symposium. So with that, thank you very much again, and have a really good night, everybody. Thanks so much for stopping by.
Thanks so much, everyone.